Okay, thank you, Nilam. Uh, so, on behalf of Acmedix, I welcome all delegates, all faculty for a very interesting webinar, which is going to be the take-home message for new ACC/AHA guideline which has come for heart failure. So, I welcome all faculty as well as the delegates, and I hand over the session to Dr. Ishwar to start the program. Thank you so much.
Thank you, Ajay Bhai, and welcome everybody. We all know that there's been a dramatic and huge change in the way that we are managing patients with heart failure, both in diabetes as well as in non-diabetic patients. We had only the old ACE inhibitors and beta blockers and diuretics for a very, very long time. And by trying to optimize the dose, we tried to manage our heart failure to the level best possible way. But the new drugs, the ARNIs and the dapagliflozin or the SGLT2 inhibitors, they have changed the way that we look at how we are treating heart failure. And now we have got so many drugs in our armamentarium, and that's why that we can improve the quality and the duration of the life or longevity also of the patients who are suffering from heart failure. In fact, we can even start treatment before the overt heart failure is there. And that's what we'll be trying to discuss today, because there was a very fantastic editorial on these wonderful 4 drugs which are, contributing to the improvement in the outcome of patients with heart failure. So we'll try to discuss these 4 drugs. So we've got a galaxy of speakers along with us. Dr. Kinjal Bhatt, a very close friend of mine. He's done his MD in internal medicine from Pisha Medical College and DM cardiology from AIIMS Delhi, doing all sorts of interventional cardiology, one of the pioneers of rotablator and IVUS and other things in Rajkot. He's a marathon runner, cyclist. He has got so many other interests also, and it's very good to see that that we are not only concentrating on the subject, the cardiology or whatever subject we are doing, and we are having other interests as well. So welcome, Kinjal, very close friend. I was instrumental in him joining us. So thanks for accepting the invitation and joining us, Kinjal. Dr. VC Chauhan again remembered me since long. Yes. He used to come to Rajkot. So, I remember those days. I think he used to come to Neelang's place.
Yes, that's very long years.
Very, very long back. When there was
at that time, there were only 1 or 2 cath lab in Gujarat. That was the first one was in Baroda at that time.
So I remember that he used to come to Rajkot very, very long back. And, he has studied from Baroda, the MBBS and MD, and got a fellowship in interventional cardiology from Sterling Hospital in 1994.
St. Vincent Hospital, Australia.
Yeah, and also been to Australia and, done this thing there. So he's also a well-known person in Gujarat. And of course, the last but not the least, Dr. Kamal Sharma, who is an interventional cardiologist, well-known person because he's a great academician, a multiple gold medalist, working with the UN Mehta Hospital as well as with the Sahal Hospital, a good teacher and, a nice person to meet and to talk with and, good person to hear also. So with this short introduction for the 3 speakers, I would just request that because we have started about 9:15 and we would like to end as quickly as possible and give time for question and answers to try to finish the talk within 10 minutes so that, we can, sort of go ahead with question and answers, because it's a very exciting topic. And for all those who are attending, it's very important to ask questions about how best to treat heart failure when it is there or to prevent heart failure, both in diabetic and non-diabetic patients. Basically, I work only in the field of diabetology, but heart failure has been of interest for me even before, I started doing only diabetology work. So with these few words, I would like to kick off the session. And the first talk will be by Dr. Kinjal Bhatt. So I would request Dr. Kinjal to please start his talk. Then we'll followed by Dr. VC Chauhan and then followed by Dr. Kamal Sharma.
Yeah. Good evening, sir. Thanks for a wonderful introduction. Good evening, Chauhan sir and Dr. Kamal Sharma, if he is there. You have to enable my slide sharing. Hello. There is some problem. Slide sharing.
Just a minute, sir.
सर जस्ट एक बार बंद करके वापस स्लाइड शेयर करिए ना.
System.
Should I say to sir RX Events to present the slides?
Okay.
Yeah, but my system got hanged. Just wait a minute. I have to restart my system. Just a minute.
Hi, good evening, Dr. Ishwar, Dr. Chauhan.
Hi, Kamal. Good evening.
Angel. Yeah,
Long
hi.
time no see. We are meeting
Yeah.
and online after a very long time. Welcome.
Long time. So, Acmedix, can we start the session? We are already 10 minutes late.
It has
good
already
evening,
started,
sir.
but there was some problem with Kinjal's slide share.
Yes, yeah, sir. Chauhan sir. So no, there is a network problem with Dr. Kinjal Bhatt. So Kinjal Bhatt, sir, are you online?
Can you share? One can share from my way of.
Okay. Yes, sir.
So I will, yeah.
Hello, Neelam ma'am, share.
Yeah, Dr. Kinjal, it's visible. Go ahead. Yeah.
Yeah, sir. You can start, sir.
So the topic is that the clinical practice guideline for the management of heart failure. The recent guideline that has come up, right? So we'll discuss that next. So heart failure basically divided into the stage A to stage D. Stage A is at risk of heart failure. Those who are at risk of heart failure but doesn't have an overt sign and symptoms. Stage B is pre-heart failure, those without sign and symptoms, but have one of the following, like structural heart disease or risk factors associated, like increased NT-proBNP or persistently elevated troponins. Stage C is symptomatic heart failure, and stage D is advanced, that is refractory heart failure that interfere with the daily life. Next. So the guideline will discuss the role of SGLT2 inhibitor. Next. So it is a class 1A indication that patient with symptomatic chronic heart HFrEF, SGLT2 inhibitor are recommended to reduce the hospitalization for heart failure and reduce the cardiovascular mortality irrespective of presence of type 2 diabetes. And it has a very good, that is intermediate level economic value. Next. So this is how we should manage the stage A and stage B heart failure. So first of all, the patient is hypertensive, then our target is the optimal control of the blood pressure. Patient, whether it's a diabetic or non-diabetic, if he is at risk of heart failure, we should initiate SGLT2 inhibitor. Cardiovascular disease, we should optimize the management. Patient is on exposure of cardiotoxic drugs like chemotherapeutic agent, then we should have a multidisciplinary approach. Genetic screening is required if there is a family history. And in patient, we should also check regularly the NT-proBNP level in this type of the patient. When there is a stage B heart failure and EF is less than 40, is initiate with the ACE inhibitors. Not tolerated, then ARBs, beta blocker will be the cornerstone. In selected group of patients, basically EF less than 30 or EF more than 40 post-MI, ICD is recommended, and genetic counseling in selected group of the patient. Next. Then we have started the drugs. Then even if there is no improvement in the outcome, if it remains less than 40, then in class 3-4 patients we can add the hydryl nitrates, ICD again in the selected group of the patient. When patient has a wide QRS, especially with the LBBB, then we can recommend CRT-D. Even though, in spite of all this treatment, patient remain in refractory stage, refractory heart failure, then we can advise him for the mechanical cardiac support in selected group of the patient. Cardiac transplant, we can enroll him for the cardiac transplant, and palliative care, investigation therapies. These are the therapies available in stage D patient. Next. These are the additional drugs we can give once the GDMT is optimized. Ivabradine when the heart rate remains more than 70 or patient cannot tolerate the beta blocker. Vericiguat when there is a patient is in heart failure class, NYJ class 2 and 4, EF less than 45, recurrent heart failure hospitalizations or IV diuretics. In spite of giving IV diuretics, the BNP levels remain elevated. Digoxin level in symptomatic patient. PUFA and potassium binders in when there is a high potassium value when we give the RAS inhibition. Next. So SGLT2 has a class 2A recommendation in heart failure with medium range ejection fraction, and weaker recommendation are made for the RD ACE inhibitors, ARB, MR and beta blocker in this population. So the second take home message is next. In patient with HFrEF and NYJ class 2 to 3 symptoms, the use of ARNI is recommended, that is to reduce the morbidity and mortality. And in patient with previous or current symptom of chronic HFrEF, the use of ACE inhibitor is beneficial to reduce the morbidity and mortality when the use of ARNI is not feasible. Next. Then in patient with previous or current symptom of chronic heart failure with reduced ejection fraction, who are intolerant to ACE inhibitors and ARNI, then use of ARB is recommended to reduce the morbidity and mortality. In patient whom with previous or current symptom of chronic FREF in whom the ARN is not visible, we can use either ACE inhibitors or ARB. In patient with FREF with class NYJ class 2 to 3 who tolerate an ACE inhibitors and ARB, replacement by an ARN is recommended to further reduce the morbidity and mortality. Next. So something that we should not do, that ARNI should not be administered concomitantly with ACE inhibitors or within 36 hours of last dose of ACE inhibitors, because it will lead to profound hypotension, many times angioedema. ARNI should not be administered in patient with history of angioedema, and ACE inhibitors also should not be administered in patient with history of angioedema. Next. Beta blocker. Generally, a HFrEF patient with current or previous symptoms, the use of any of one of three beta blocker, that is bisoprolol, carvedilol, and sustained release metoprolol is recommended to reduce the mortality and hospitalization. And beta blocker therapy has a high economic value. Next. So mineralocorticoid inhibitor, that is spironolactone. So patient with HFrEF and class 2 to 4 symptom and MRA, that is spironolactone eplerenone, is recommended to reduce morbidity and mortality. If GFR is more than 30 and potassium level is less than 5, careful monitoring of potassium level, renal function, and diuretic dosing is recommended whenever we give mineralocorticoid inhibitors. And it has a high economic value. And when it is very difficult to maintain the potassium level less than 5.5, mineralocorticoid antagonists should be discontinued because there is patient at risk of life-threatening hyperkalemia. Next. So again, we have already discussed that ivabradine when heart rate remains more than 70 or beta blocker not tolerated, vericiguat in selected group of the patient in EF less than 40, 45, recurrent heart failure hospitalization and elevated NP level. Digoxin, it has a symptomatic benefit, no mortality benefit, and potassium binders when potassium level remains persistently high. Next. So the third take-home message is new recommendation for heart failure with preserved ejection fraction are made for SGLT2 inhibitors, MRAs, and ARNIs. Several prior recommendation has been renewed, including treatment of hypertension, that is class 1 recommendation, treatment for AF, that is class 2 indication, use of ARBs, 2B indication, and avoidance of routine use of nitrate or phosphodiesterase inhibitor, that is a class 3 indication. Next. So improved LVEF is used to refer to those patients with previous FREF who now has a EF more than 40%. This patient should continue their FREF treatment. Next. Value statements were created for selected recommendation where high quality cost effectiveness studies of the intervention has been published. I think this is the last slide. Next. Thank you.
Thank you, Kinjal. You have taken us through the first 5 recommendations, and I would request Dr. Chauhan to, we already introduced the speakers. Kamal joined a bit late, but we have introduced everybody. So we won't waste time with that. I would request Dr. Chauhan to take over and go through the rest of the recommendations so that we can go ahead with the rest of the program.
Now, before the issue, can I have one comment on Kinjal's lecture?
Yeah.
Yeah, because see, basically, at the moment, recommendation for heart failure treatment remains more or less same, whether it's reduced ejection fraction, medium range, improved, or even preserved ejection fraction. In that, he's mentioned 3 medicines, but not beta blocker. I would add to that, even in patients with preserved ejection fraction, if they have hypertension, ischemic heart disease, resting tachycardia, and no contractility, beta blocker also has to be added. So that is an important thing that I wanted to add. Okay, now can someone put my
Yeah,
slide
perfectly.
now?
Okay. So what we'll do is you continue with the lecture, and then I think whenever we are having the question and answer,
Yeah,
it's a very important point to discuss.
No problem. Sure. Yes, so next slide. Because I don't have control on my slide at the moment. Now see, we have many lectures on patient with heart failure, and where 4 medicines have been discussed repeatedly, symptoms, signs, and other things. But there are very few cases where specific discussions have taken place. As for example, about rare disease, infiltrated disease like amyloidosis, sarcoidosis, hemochromatosis. So today I'm going to discuss about some different messages, which are little hatke, you can say little hatke messages. So amyloid heart disease is a new recommendation for treatment in which you have to give very high suspicion, because otherwise you cannot diagnose amyloidosis. So whenever you have any patient with a heart failure with preserved ejection fraction, keep amyloidosis in mind, and we can take care of our hematological colleague. They can help us come at a diagnosis. There are some special tests for the diagnosis of amyloid disease apart from echocardiography and cardiac MR. These tests are probably not under purview of us, but hematologists can do this test, like serum and urine, monoclonal light chains, bone scintigraphy, genetic sequences, as well as some specific treatment. I don't know what is tetramon stabilizer therapy, but anticoagulation may be considered, especially if there's associated atrial fibrillation. Next. Yeah, next slide. I think 7 number is missing. Next will be 7. Yeah. So see here, I think there is no direct relation with all the slides. But the 7th, there are 10 messages of American Heart Association Jack. So 5 has been already said. 6 I said. The 7th one is evidence supporting increased filling pressure is important in diagnosis of heart failure, especially if ejection is 40%. See, in past, like more than 10 years ago, whenever patient is present with heart failure symptoms, and we do echo and ejection fraction normal, we tell patient, don't worry, it's psychological, your heart is abnormal. Now we realize that even with normal ejection fraction, or sometimes even with super contractility like 50-55%, patient can still have heart failure. So if there are symptoms of heart failure, signs of heart failure, even if echo is normal, we have to prove the diagnosis. And for that, now there are some echo criteria, as for example, reverse EA ratio, hypertrophy of the heart, dilated left atrium, and high pulmonary pressure. We can make out that this is a patient with preserved ejection fraction, and still he is in a heart failure. And fortunately, now we have natriuretic peptide, anti-pro-BNP, which is very robust and very important tool for the diagnosis as well as prognostication and to see the efficacy of medical treatment. In past, we used to do left ventriculogram in each and every patient where we do angiography. Nowadays, because of echo, we don't actually enter into the left ventricle. But still, if you enter the left ventricle with invasive phase, we can measure the end diastolic pressure is high. And this is how we can diagnose patient with preserved ejection fraction. Next. Now, basically, patient who have advanced heart failure, our aim is to see that their quality of life improves as well as it prolongs the quantity of life. And some studies show that if you put patient on all 4 standard guideline-directed medical therapy in adequate dose, it's possible that you can increase lifespan by 6 to 8 years. And this is, I think, really a very big achievement. Of course, those patients who are in advanced heart failure, like stage D, as for example, in spite of maximum malignant therapy, we can add some palliative therapy. Patient who has a poor ejection fraction, giving intermittent inotropic therapy, like dobutamine, as for example, may improve symptom temporarily. Of course, that does not improve the long-term prognosis, but we do give dobutamine infusion to some patient whenever there's significant congestive symptom. Maybe dobutamine infusion for 24 hours can improve the efficacy of diuretics. Of course, you have to be careful that it doesn't cause tachyarrhythmia or ventricular tachycardia and other symptoms during that infusion. Next. Next one, ninth message. Again, as I said, these slides are not in that particular order, but 9th is prevention. Prevention is most important in coronary disease that we know. Even in a heart failure patient, prevention probably plays very important role. And we now know which are the risk factors, which Kinjal has very nicely elaborated, which are the risk factors which increases patients' chances of going into the heart failure. So if you have any patient who has, as for example, hypertension, diabetes, even if they have normal echocardiography, even if you have no symptoms of heart failure, try your best to control these primary underlying risk factors so that you can prevent development from stage A to stage B or progression of stages to stage B. That is, I think, one of the most important things that we should learn as a physician, as a doctor, to treat the patient who are at risk for the heart failure. Next. And as again Kinjal has mentioned, that in patient with heart failure, treating with 4 pillars is definitely most important, but there are few additional treatment. Most important thing is to take care of associated comorbid factor. As for example, iron deficiency anemia. There are many patients who may not have anemia, and still they may have iron deficiency. So it is recommended that in each and every heart failure patient, especially when they complain of severe weakness, fatigability, even if you reduce the dose of diuretics, even if they are otherwise stable, you must get iron level is low. It is advisable that we give them intravenous iron ferric carboxymaltase. Giving oral iron doesn't work here. It has to be intravenous because then only it works. So if, of course, if there's anemia, we always investigate for the iron deficiency, find out why there is iron deficiency. Hypertension is always important risk factor, hypertension and diabetes both, and they require aggressive treatment right from stage A to stage D. Sleep apnea is now, we have seen more common than we ever imagined. It is because our suspicion level has gone down, and that's why we diagnose too many patients with sleep apnea. And remember that sleep apnea can occur not only in obese patient, even in thin person or medium range patient, sleep apnea is possible. So always ask history of snoring and daytime somnolence to the patient who have a heart failure. Atrial fibrillation can cause heart failure, as well as it can cause a lot of other disasters like peripheral embolization. So rate control is most important in patient with atrial fibrillation. And there are some patients with refractory heart failure where if you do actually ablation, nowadays cryoablation or pulmonary vein isolation, we can actually take care of atrial fibrillation. We may have to put a pacemaker, dual chamber in that condition probably. But that is one of the reasons to control refractory heart failure if atrial fibrillation rate cannot be controlled. We always do beta blockers in adequate dose, then digoxin to control the atrial fibrillation, sometimes amiodarone if they don't have hyperthyroidism, and sometimes flecainide. There are few medicines available to control the rate, but if refractory heart failure doesn't go away, rhythm conversion to sinus rhythm is most important. But converting atrial fibrillation to sinus rhythm doesn't remain in long time, and so our aim at the moment is just control of rate. But if you can do ablation, probably it works well. Coronary artery disease is cause of heart failure 50% plus patient, and I have seen many patients where you do bypass surgery or even major vessel angioplasty, LV function improves quite significantly. Malignancy itself per se doesn't cause heart failure, but some of the medicines are cardiotoxic, doxorubicin S for example, and it's better that we should monitor these patients periodically when they are on cardiotoxic malignancy drugs or anti-cancerous drugs. I think this completes my lecture. The time 10, this is the next slide, if there is any next slide, or we can go to the third speaker, who is Professor Kamal Sharma.
Yeah, so thank you, Dr. Chauhan, for that, completing those other 5 recommendations. I will hand over the mic to Dr. Kamal Sharma for for his talk, and I already introduced him. So again, I will request Dr. Kamal to keep it possible within 10 minutes, so that I'm more interested in question and answers, because that's how we can take forward the messages which have been given by the by this august combination of bodies, which have given fantastic, I think, really good guidelines and put it properly so that we don't miss anything. Over to you, Dr. Kamal.
Thank you. So fantastic talk by both the speakers. I think there is pretty much little to add. So I'm just touching upon the 2022 AHA-ACC HFSA guidelines for management of heart failure. So the final thing that we can try to summarize is that the clinical assessment, of course, must always include good history taking and exam. Initial lab and ECG testing apart, use of biomarkers is something recommended for prevention, initial diagnosis and risk stratification. Selected potential causes of elevated natriuretic peptide, gene evaluation and testing, and evaluation with cardiac imaging with exercise and functional capacity testing is something recommended. This is pretty much known. The stages of heart failure, I'll just skip this. I think Dr. Kinjal also touched upon it pretty well. Stage A is patients with at risk, and stage D would be the patients with advanced one. So comorbidities in patients with heart failure, hypertension, diabetes, anemia, amyloid, and other things that were discovered by Dr. V.C. Chauhan as well are this couple of other things that one should be watchful of. But very importantly, you should not miss out on disorders that are more prevalent, that includes diabetes, heart failure, OSA, anemia, etc., including from the India B study, which was funded by the ICMR, which had almost 50% of the patients who had chronic heart failure were diabetics. And this is very much a likely association, because diabetics tend to have more heart failure, and heart failure patients tend to develop new onset diabetes as well. What's new in the therapy is tafamidis, which is primarily used for management of triatheritin, or what you call as ATTR amyloid, and binds the thyroxine binding site of transthyretin, demonstrated reduction in ACM and CV hospitalization. Canakinumab, which is interleukin-1 beta antagonist, which has been studied in patients with acute coronary syndrome in CANTOS trial, and now it's been shown also to show in the extended follow-up heart failure hospitalization reduction, especially if there was elevated hsCRP. So management of AFib, cardio-oncology, cardiac therapies associated with cardiomyopathy, and recommendation of patients' reported outcome and evidence gap with future directions is something that's been also touched upon. So I think I'll finish this session here because there is no point in repeating what already the two eminent speakers have covered. I think, as Dr. Ishwar mentioned, we should probably be doing more question answer rather than going through the slide deck. Over to you, Doctor.
Yeah, thank you, Kamal. So I would like to set the ball rolling by asking a question to all the three cardiologists, and maybe Ronak is also there. So Ronak also I would like to ask that, if there is a patient having an overt heart failure, he may be a diabetic patient who is being seen by me, or he is being seen by a physician without diabetes or with diabetes. Do you think that the right person to manage him would be a cardiologist? Because, you'll be able to monitor the proper drugs and what is going on and take care of other things. Do you think that physicians are properly, have this thing and wherewithal or know-how to manage advanced or, moderately advanced heart failure in a proper way? Or I think it's the cup of tea which is best left to the cardiologist. It's a very controversial question, but, even now in the big cities where PAMI is available, thrombolysis is being done. So it's controversial, but I think for the patient, if the cardiologist is taking care of moderate or severely advanced heart failure, I think it will prolong the duration of their life and, see that the best treatment is given to them. So Kinjal and then Dr. Chauhan and then Dr. Kamal, a controversial question, but your quick take on that.
Yeah, agree that it is a really complex situation that who manages, right? So if the patient comes to the cardiologist, right, then heart failure part and the cardiac part he can manage very well. But the advanced disease is there. Basically, he has other comorbidities like the advanced diabetes, right? So then he has to refer it to the endocrinologist or the person who manages the diabetes, basically the physician who are expert in the diabetes, right? So my take, that is a multimodality approach in this type of the patient is the best for the overall management.
Thank you, Kinjal. Dr. Chauhan, your take on it?
Yeah. See, basically, as far as medical management of heart failure is concerned, a very good senior or very good experienced physician can easily manage that patient unless they have to undergo some procedure, like as for example, angiography followed by angioplasty or bypass surgery, or CRT device implantation, ICD implantation. In that situation, cardiologist is definitely required. Or in spite of maximal effort, suppose physician feel that the patient is not responding well and refractory, maybe he can refer to cardiologist. But I think 80% patient can be very well managed by a physician because they can give all the medicine that cardiologists can give. They can monitor the patient equally well. We have too many symposium, webinars and other knowledge exchange that everyone who is a good enough clinically can manage heart failure patient. But as Kinjal very rightly said, it's a basically teamwork. There are many patients who have cardiac problem and some non-cardiac issues where we definitely require help of a good physician. So it's a mutually supportive world.
Kamal, your take?
Well, I think every cardiologist needs to learn some diabetology, and every diabetologist has to be a cardiologist. So we are back to 3 decades back when we were entering medical school, that every physician was a cardiodiabetologist. So I think you may do DM, but we'll be back to square one. We'll have to do a DM either in endocrinology or cardiology, but you'll have to learn diabetocardiology. On the serious other note is that yes, when a heart failure patient with diabetes would come to a cardiologist, he must be aware what therapies he would be using for the cardiovascular benefit upfront, And on top of that, I would be including a diabetologist to optimize it further, which means that I would be focusing very strongly on therapies like GLP-1 analogs, metformin apart, SGLT2 inhibitors. Think of ARNI, because we now know that ARNI usage actually reduces the need for insulin. There is some very minimal effect of ARNI in terms of glycemic control or initiation of new onset of diabetes. Also would be aware of NOD with statin. So it's an amalgam of a lot of things coming in, and there is a lot of interplay between the two sciences. So I think who would be better? Either ways, whosoever initiates, it's fine, but you will have to involve the other guy. Diabetologist will have to call in a cardiologist, and a cardiologist will have to involve a diabetologist beyond the common therapies that exist.
Thank you, Kamal. I think that is a very absolutely correct thing. I just want to ask all of you again that now we have got the evidence about SGLT2, improving the outcomes in heart failure patients. How frequently do you use SGLT2 to treat heart failure in non-diabetic patients? Of course, in diabetes, it's absolutely, there is no question, you have to use the drug. And in fact, now, as far as we are concerned as diabetologists, unless there is a contraindication, we give this group of drugs to each and every person, because it has got renal and cardiac and, so many, out of the box things which are coming. So GLP-1 and SGLT2 for us have become very, very important therapies, and, leaving aside the sulfonylureas, which were the common drugs which were used previously. But now with all the evidence, do you tend to use SGLT2 as a primary therapy or as an add-on therapy in all your patients or many of your patients, even though they may not be diabetic, but they are having heart failure? Angel, and then Dr. Chauhan, and then Dr. Kamal.
Angel, you are muted.
Angel, you have to unmute.
Yeah. So SGLT2, we have started to using in some of the patients, but still a primary therapy, right? So because we have a wide experience with the drugs that we are using since long. So this is a new drug that we have started in selected patients, basically who are diabetic. And a few of my patients who are non-diabetic, they are on SGLT2 inhibitors. But still, I am a little bit hesitant to use it as a first-line drug. So this is my take.
Yeah, see, my take is usually nowadays, because of so much robust evidence and even personal experience, I put almost my 99% patient on SGLT2 blockers, either dapagliflozin or empagliflozin, irrespective whether they have diabetes or no diabetes, irrespective of LV ejection fraction. It has to be heart failure. It's like with ejection fraction, if patient has clinical evidence of heart failure or elevated anti-pro-BNP, I put almost all patient on one of the SGLT2 blockers. Only problem is 10 to 20% of my patient, they get urinary infections or they cannot tolerate it. So especially elderly lady with diabetes, many times we avoid SGLT2 blockers. So during perioperative period or whenever there is any infection, we avoid them. But my use has increased significantly as a I don't consider add-on therapy. It is started as early as possible. And I think after Kamal, Ronak also should answer his views.
So I will just tell that initially when the data is coming, I have also started using it. But you are very right that urinary tract infection is very, very problematic. So that's why I have to curtail my use, because basically whenever we give to female, they are at
very common.
somewhat high risk of developing this.
So if I have a heart failure patient, very sick heart failure patient in the hospital who is having urinary catheter, as for example, urinary catheter, I usually avoid starting SGLT2 blocker.
Yeah.
No, I start it up front. I don't hesitate to use it, especially when the patient is non-diabetic. More so because we know that in non-diabetics, there's going to be very minimal glycosuria in heart failure. And that's why the risk of UTI, if you look at in the DAPA-HF trial, or even if you look at the Emperor reduced, the incidence of UTI was as good as placebo or as bad as placebo. So the good advantage of using this therapy in non-diabetic heart failure is straight away, there is no side effect at all, except even when you look at the euglycemic ketosis incidence, it's equal to placebo in non-diabetic SAVA. So it's only the trouble is when you're dealing with a diabetic heart failure. So it is indeed one of the first pillars to add, because even if you have, except the acute CKDs, I mean acute and chronic CKD, or acute worsening, AKI, not a CKD, where I would desist using for this. But even in CKD, when we know from DAPA CKD trial that this is going to be beneficial. Actually, I see a lot of patients who have been seen by nephrologists and diabetologists, but have not been put on DAPA, and they are not still in overt heart failure. I initiate them on DAPA. And then I tell them that when you meet your nephrologist friend, just make sure that tell them that Dr. Kaman initiated this and he was asking about this drug, what to do. And that drug is marked as a diuretic. And I tell them why. I mean, I tell the patient to ask the nephrologist how to titrate in light of me initiating DAPA in a CKD background, which is like CKD3. So I upfront use it. I have no hesitation to use, not to use. I mean, there is no reason for me not to use it. I think unless you have an acute pyelonephritis or a renal abscess, or you have a very bad recurrent lower respiratory, lower urinary tract infection.
Very unlikely. Very unlikely.
So I usually go and I just even for a patient who comes with fungal infections or even comes with UTI, I do re-challenge them. I put them on a single dose, try to send for a culture. Most of these are sterile. Most of them will be fungal. I just have to tell them that drink a lot of water, always clean the genital parts after urination, which is a big problem in India. Males don't wash their genitals world over after urination, unlike females. And hydrate yourself well. And that's the thing. And most of the patients actually do well on the re-challenging with the SGLT2. So they are pretty safe drugs. I mean, I call them the cheaper Vericiguat now, because like Vericiguat you can use in hypotension, renal failure. That's something that you can use now with the patent getting off. DAPA has become cheaper. You should probably be initiating it much earlier, probably even ahead of ARNI. That's how the proposal was by the group which talked about initiating beta blocker SGLT2 ahead of ARNI. But again, that's another topic. If we raise, I usually initiate all four in one go, maybe one for half the dose or 1/4 the dose at the first meet and up titrate all. Because DAPA, you don't have to titrate. Beta and ARNI, you can always. And I take off diuretics. I can take off diuretics barring MRA and instead continue with DAPA. We have data now from MPulse, which talks about even in acute heart failure. And that makes me more secure to start that therapy in acute setting as well. Dr. Ronak, your comments?
Yes, sir, I totally agree. Dapagliflozin has to be started as early as possible. Even before ARNI, when patient is on inotrox also, we can take risk to start dapagliflozin in such patients. But all physicians, that will bring us to the first question also, all physicians and everyone must know that there are some patients who are going to get urinary tract infection with dapagliflozin. And because patient will go to physician first with urinary tract complaints and not to a cardiologist. So all physicians should know that this could be the reason and this should be worked up. Although maybe it is maybe 1 or 2 out of 100 patients in India. But yes, it should be known to all physicians. And yes, I do recommend that we should start using dapagliflozin more and more, because till now also maybe 5 or 6% of heart failure patients are getting covered with dapagliflozin. Even in cardiology practice also, we should increase it more.
In fact, Ishwar, now it's more known to us as an anti-failure medicine rather than anti-diabetic.
Yeah, it is no longer a diabetic.
So it's a more anti-failure medicine.
It is a renal drug, it's a cardiac drug, it is not a diabetic drug. So my next question is to all of you is that where have the diuretics gone? We have not even discussed diuretics, which I believe is still, in an overloaded patient is a cornerstone of therapy. And where has the lanoxin gone? Of course, we never use nowadays because of the, the narrow therapeutic window. So what is the role for using, except to control the heart rate in atrial fibrillation? What is the role of using lanoxin? Should we use it routinely? And when should we use diuretics and when should we stop? And, just today I saw a patient with a prescription for potassium sparing also. So should we, because we are giving ARNI and, we know that hyperkalemia and all these things can occur. So should we use a loop diuretic only? Or if we are using diuretic, should we combine it with a potassium sparing? Or should we use diuretics at all, or when should we stop it? Angel, can you start off?
Yeah, because diuretic depends upon what stage of the heart failure it is. If it is very much improved stage, then there is no point in adding diuretic. So when we see that he is on fluid overload, in spite of giving all medicines, basically the now SGLT2 inhibitor, then we add diuretic. In heart failure, always the diuretic I use is loop diuretic. Unless the patient is hypertensive, in that case, we can change his medication that include the thiazide diuretic. So if he is not controlled with the thiazide diuretic, hypertensive patient, then we can add the loop diuretic. And regarding mineralocorticoids antagonist, right, there is a spironolactone, eplerenone. So when we are adding it with the ARNI or ACE inhibitors for ARB, then we should be extra careful for developing hyperkalemia. And with so much of the drug, then there is also when we use the spironolactone, and it can also lead to the hyponatremia also, because it preserves potassium by nitriuresis. So that we have to take care of that also, basically in elderly patient. So whenever we use the diuretic, then is all this, because loop diuretic with mineralocorticoid inhibitors, then we have to monitor electrolytes, renal function quite often. And regarding lanoxin, it is very sparsely we are using it whenever we cannot control the heart rate, or there is the last drug that we will use in this of the patient, not a first line drug or not even a second line drug. The third line drug, that is we use, basically I use lanoxin.
See, diuretics is still one of the most important medicines, especially loop diuretics, acute decompensated heart failure. And nothing works better than diuretics in that situation, especially if patient comes with severe heart failure, marked tachypnea, Philip class 4 heart failure. IV furosemide or torsemide works better than any medicine. But as patient improves from the heart failure, we gradually reduce dose of the medicine. But there are some patient, chronic heart failure patient who may have congestive symptoms. We have to go diuretics. So what I usually do is gradually reduce dose of diuretic as per the clinical signs, symptoms, and I tell patient daily to do the weight, look for the edema, and maintain the fluid balance very well. Because in chronic patients, if you can reduce diuretics, you can probably increase rest other medicines. So in acute phase, diuretics are definitely priority. Later, we reduce them so that we can increase dose of ARNI or other equivalent medications. So diuretics plays very important role in acute situation and to some extent in chronic. And I tell all my patients when to increase the dose, when to decrease the dose. So that case makes a lot of clinical just sense. As far as digoxin is concerned, I agree with Kinjal. Patient with atrial fibrillation, very fast heart rate, when beta blockers cannot control it, amiodarone cannot be given or it is already given and still heart rate is fine. I always add lanoxin, and it works very well to control the rate as a third additional medicine. And those patients with severe LV dysfunction, especially ischemic or non-ischemic cardiomyopathy, sometimes giving lanoxin, especially in tachycardic patient, it at least reduces the heart failure admission and some sense of well-being, though it may increase mortality by increasing arrhythmia.
Kamal, your take?
No, I agree. I mean, when your patient is congested, you need to be choosing appropriately how much of diuretics you want to give. But I would, barring MRA, I would not be very keen to, substitute diuretics instead of the 4 pillars. So I'm more aggressive on 4 pillars, except for the acute congestion, according to the hydrostatic pressure. And of course, with an SGLT2, you would probably get more margin or leverage to reduce interstitial fluid, because that's the mechanism of SGLT2. It takes away the fluid from the interstitium, that's the pulmonary edema or the interstitial edema, wherever it may be. Only the extravascular volume is something that we maybe, or some amount of intravascular volume, which is lost with diuretics, which may actually be detrimental to cause more renal failure. And that's why, barring the overweight or the extra volume that is intravascularly present, I would not be chasing it in the acute setting. Again, there are trials like SOAP trial. There are trials which have looked at bolus trial, which have looked at the high bolus dosages versus the infusions of diuretics in the acute hospitalized versus the dose of diuretics, how much negative you do, what is the incidence of AKI. All said and done, I think once you're done with your job, it's like paracetamol. You have fever, give it, and once you're done with it, stop it. You don't have to keep it around the clock. So that's the thing that you need to watch, barring the MRA. Digitalis, I'm a fan. I still use it in all my class 3-4 patients, maybe because I see more of class 3, because class 1-2 would not come to a cardiologist like us. They would be mostly with physicians. And most of these patients who are class 3-4 are already exhausted of the 4 pillars by the time they come to me, especially in atrial fibrillation. with class 3-4, we all know from DIC trial subgroup analysis that in patients whose serum values are less than 0.9 to 1, that these patients actually, if discontinued, will have worsening of the outcome. So either ways, AFib with LVD, always use. Rheumatic heart disease, AFib, again, I use. But otherwise, in hospitalized 3-4, with sinus rhythm, when I've exhausted therapies, I again use digitalis.
Very
Ronak.
true. Yeah, very true, sir. So
Ronak,
diuretic,
your take.
loop diuretic. Yeah, like loop diuretic. We have only role in acute decompensated heart failure. And more we start ARNI or more we start SGLT2 inhibitors early in the course of therapy. All of us will realize that diuretics are not compulsory except MRS. So loop diuretics, once you start ARNI or SGLT2 inhibitors, you can reduce down on loop diuretics or you can stop it at all once you have started this neprilysin inhibitors and all. So diuretic is not one of the pillar except MRA. MRA gives this mortality benefit in heart failure patients also. So MRA has to be given in as a fourth heart failure pillar. Regarding digoxin, I am not a very fan of digoxin. I do give it only in atrial fibrillation patient when they have heart failure. Otherwise, I don't use digoxin much. So I won't be able to comment on that digoxin part.
So the last question, because we are running short of time, if you can give a single word answer, what is your favorite beta blocker among the three to use in heart failure? For example, I am a fan of carvedilol for heart failure. So Kinjal, Dr. Chauhan, Dr. Kamal, and Dr. Ronak, is there a preference for a particular beta blocker or you use all the three? Kinjal?
Yeah, I use carvedilol.
Dr.
I
Chauhan?
use, if patient is ischemic heart disease, I use more beta blocker in the form of metoprolol. Otherwise, in heart failure, metoprolol and bisoprolol are almost equal amount.
Dr. Kamal?
Bisoprolol, because carvedilol, I don't see anybody reaching 25 BD, which is the recommended dose.
Yes.
And bisoprolol also, because I have been a principal investigator and have seen my real world experience with investigator-initiated trial in tenacity, which is a big published data now. I'm a very big bisoprolol fan. I use it very aggressively unless I have ectopics where the anti-arrhythmic action of metoprolol is superior. But if you have non-ischemic cardiomyopathy and patient has hypertension and can tolerate, then I would go carvedilol 25 BD. Once I initiate, I always make sure that I reach that dose.
Maximum dose, yes. Dr. Ronak?
Carvedilol or bisoprolol? You say bisoprolol.
Definitely.
I use bisoprolol.
Depending on
I
what
use
is
bisoprolol, but if I start carvedilol, I'll make sure that I reach 25.
Okay.
Ronak?
Definitely. Non-ischemic patients, bisoprolol. COPD patients, bisoprolol. Ischemic patients, metoprolol. Carvedilol, no.
Okay, thank you so much. So we had a nice discussion and good question and answers. So I'll wind up this session. I will hand over to Dr. Ronak, who is working with Bankers Heart Institute in Baroda. He worked as an intensivist in Holy Saints Hospital, and thereafter he has done his DNB from Nanavati Hospital in Bombay, and now he is working with Bankers Hospital. I will hand over the next part of the session to Ronak to please proceed. Thank you so much.
Thank you, sir. So I don't have any presentation to present. So let's go directly to we continue the question answer session. So I would like to ask all of you that now after reduction of price of ARNI by multiple companies, what's your take on use of ARNI? Would you start it early? Would you start in acute decompensated heart failure when patient is admitted? Or would you wait for the ARNI to be started? Kamal Sharma, sir, first. Yes, sir. Kamal, sir.
Sorry, I lost the network in between. What was the question, Ronak?
Okay. So after price reduction of ARNI, what is your take on use of ARNI? Would you like to start it earlier the possible, or would you like to still wait for the
No, even when the price was high, I was always on ARNI, and I'm still a pure ARNI guy. And there is no ARB or ACE in heart failure for me. And as I said, the very valid point that I do start all four together, because you can't go by the protocol of McMurray et al., who talks about giving BSGLT2 beta blocker first and then calling them back and initiating other two later. And then most of these patients, when they reach us, are pretty sick. They are class 3, 4. No class 2 patients would come to us. So by the time they've reached us, they are already exhausted of those basic digitalis and beta blocker kind of stuff. And I think they are already on either ACE or ARNI when I see them. And of course, the guideline tells you as a class 1 indication to switch from ACE ARB to ARNI. So I'm upfront ARNI person if there are no contraindications.
Okay, so to VC Chavan sir, after starting ARNI, how frequently you would ask patient to have a repeat visit OPD, and which investigations you would like to recommend to this patient, and how frequently you would like to recommend investigations to this patient?
See, once RD started, I usually call patient on 2 to 3 weekly interval for first 2 or 3 times. And usually I concentrate more on sodium, potassium, and creatinine. And when they come for the follow-up, sometimes I do echo screening, but always obviously maintain the blood pressure. If blood pressure is more than 100 and there are no signs of hypoperfusion, usually I step up the dose of RD, even if they feel clinically better. So I try to give maximum possible dose of RD tolerated on basis of blood pressure, as well as on basis of creatinine levels, and obviously on basis of pocket. And like Kamal Sharma said, even before RD prices went down, I was very much fan of RD because I saw some results. See, 10 of my patients were planned for the CRTD. After putting the RB, actually there was no need for CRT. So have you seen the robust clinical personal improvement in the LV function? So even before, I used to start RD as a first drug, not trying first AC inhibitors or ARBs, directly RD. That is what we were doing. And this is how I follow up. And once patient is stable, I try to maintain whatever maximum dose patient can tolerate unless there is some contraindication. And that even after the ejection fraction improves and remain preserved, I continue it. Of course, at that level, some patient, because of financial reason, wants to go, then I replace it with the Valsartan. That is what I usually do. But if they can afford the cost, yes, I continue with the highest possible tolerable dose.
Okay, so Dr. Chinchal sir, how you would start ARNI? Like you start from low dose, titrate it up, or directly start with a higher possible dose?
Generally, I start with the low dose. Depend upon the blood pressure. If BP is more than 100, then I start with the 50 md. If BP is less than 100, then I start with the 25 milligram BD and gradually titrate the dose. So this is how I start, and I will call patient again on 1 to 2 weeks later to check his blood pressure and RFTs with electrolyte.
See, Ronak, if patient is coming for the first time without being on any ARNI, ARBs or AC inhibitors, then I always start with 50 milligram and then gradually increase 50 BD and ultimately 100 BD and then 200 BD. But if patient is already on reasonable dose of, let us say, Losartan 50 milligram BD or Valsartan 160 BD, I replace with directly 100 or 200 milligram of ARNI rather than gradually upstaging.
And how much BP do you accept in a repeat OPD visit? Maybe 90, 80, or you more concentrate on patient symptoms?
We take care of both the things. See, blood pressure has to be ideally 100. Of course, there are studies and trials which show even 90 blood pressure is acceptable. But I've seen that many Indian patients, especially in our hot summer, if pressure is between 90 to 100, many of them get hypotensive symptoms. So if there is no hypotensive symptom, 90 plus, but otherwise for safety person 100 plus, that is what I prefer the blood pressure to be.
Can I ask a question in between?
Yes, definitely.
I just want to ask all the cardiologists, all of you who are there, that do you do ferritin reasonably frequently, not in each and every patient, but do you think you should be doing ferritin in each and every patient and giving total dose iron? Because if that is the reason why, they are having the symptoms, then it's going to improve the symptoms in a very big way. So what is your take on the ferritin? Because in India, where we are, we accept 10 and 11 hemoglobin as a very normal hemoglobin, while actually, in foreign countries, it's 14 and 15. So what is your take on doing ferritin and giving total dose iron so that, because that is going to improve the symptoms phenomenally. So what is your take on that?
We do it in all heart failure patients at the first visit. And thereafter, if patient complains of severe weakness or if clinically we find the hemoglobin is low. So, and maybe once in a year regularly. But of course, there may be various strategies. But I have realized giving IV iron Means ferric carboxymeters makes huge change in symptoms. Means tremendous improvement in fatigability, even if hemoglobin is normal.
Dr. Ronak?
Yes, sir, definitely. It should be done in all patients as much as possible. Even off lately, since last year and a half, we have started doing it in almost all patients. And that has also seen a tremendous response. Even to certain extent, the hospital readmissions has also been reduced. So quality of life definitely will improve. But I use ferric carboxymeters, no other any iron preparation.
Angel?
Yeah, same. I use quite frequently.
And Kamal is not there. Is Kamal gone or Kamal is there?
Yeah, I'm here. I'm here.
Okay. Yeah, there you are. Okay,
Yeah.
I can't see you.
So yeah, I think my philosophy is slightly different. Again, during COVID times, people do a lot of were coming up with their own ferritin levels. You don't even have to order it. Now I go for hemoglobin in the sense that we know that for up to 13.5, injectable FCM is indicated. Most of our patients who are anyway in the range of 10, 11, I don't even look at ferritin. Because even if they're ferritin, unless you are suspecting from Menzer index that we know of, which you think is a thal minor, where you have a suspicion looking at the MCV square into RDW divided by. So Menzer is now mentioned by most of the hemoglobin. And then you know how their mean corpuscular hemoglobin or mean corpuscular cell volume, MCV or MCHC or MCV, which will tell you whether you're dealing with an iron deficiency or not. So even if I have a patient whose hemoglobin is say 11, 11.5 and is a heart failure, I would be very strongly suspicious. And if the patient is indoor and hospitalized and a blood is being sent, then I would order a ferritin. If blood is not being sent and patient is hospitalized with say hemoglobin of 10, he otherwise even becomes a candidate for IVFCM. So I would instead save that money of ferritins 1,000 rupees and put it in that 3,500 ka IVFCM and save his $1,000 there and say transfuse him with IVFCM. So that's what I do. But yes, otherwise, in a patient who's refractory heart failure on 4 pillars and even having hemoglobin less than 13.5, if I have to intend to inject IVFCM, I send for ferritin.
One more question is that we are not blacks, but we are also not whites. We are brown. So what about that fantastic hydrolysine nitrate combination? Because in some patients, it gives fabulous results. Until Arni and the SGLT2 came, it was one of the mainstays in people who are having refractory heart failure. So do you still use this combination of hydrolysine nitrates, or maybe you have not used it, or what is your take on that? Can we start with you, Kamal?
Yeah, I do use it, especially in patients where I can't use Arni. The data is missing for Asian Indians. It's high time that we come up with. I've spoken to a couple of pharma companies. They are not interested because they are selling me and otherwise. I think the data is missing from the Indians' perspective. We need to look into that, but we clinically do see response, especially as a drug where the creatinine or EGFR is not good enough to allow me other drugs, or patients who can't be given ARNI or ACE or ARB. So that subgroup, I do use it and do use it very frequently. A lot of times I do use it in patients with CKD on MHD, on maintenance dialysis, because that's also used as an antihypertensive with a theory that maybe it will work for kidney protection as well.
Ronak?
Hey, even in pre-Arni era, we have used it many times for severe MR patients to reduce afterload. So yes, hydrolysine nitrate combination I do use very frequently. Nowadays, after Arni price is reduced, the number of patients on this combination has gone down. But it is a fantastic drug, and when what Dr. Kamal sir said, it is very right. When we cannot use Arni, like in CKD patients or patients who have deranged renal functions on Arni, that this drug will work as a fantastic drug, and it can be used in Indians. Yes, it gives results.
Angel?
Yeah, same. I use when CKD patient or whenever we cannot use the ARNI and this type of the patient, I use this combination. It is a very useful combination. It gives us a quite satisfactory result in selected group of the patient.
And Dr. Chauhan?
Yeah, I also use it quite frequently. Again, more often in patient where creatinine level is high or CKD patient. But not only that, those patients who do not have CKD, if they are already on an optimum dose of RD and they have high blood pressure. So if they are on optimum dose beta blockers and RD, still blood pressure is high, instead of adding amlodipine or nifedipine or prazopressine, I would add as a third drug is hydralazine. And we have given up to 1 TDS dose in such situation. And So renal failure patient and refractory hypertension patient with a heart failure, it works quite well.
One more question I wanted to ask all the cardiologists that, see, I am a diabetologist, so we do see occasional heart failures who are advanced. But since you people are cardiologists, all the physicians and diabetologists and their heart failures will be coming to you. So how frequent is it? I mean, we know that, the renal failure is quite common in diabetes and, the foot problems are very common. And now we are talking about liver also. Is it that frequent that, diabetic people end up with heart failure? And how much of difference have this drug made in your life, and in the life of the patients? So both these things, if you can answer, Doctor, starting with Dr. Chauhan. You are muted, Chauhan. Dr. Chauhan, you are muted.
Yeah, I think this drug has made huge difference in patient's life as well as cardiologist's life both. It's made both of us very happy with the results. So in diabetic patients, as you know, it's a ischemic as well as non-ischemic cardiomyopathy. And I think both these conditions, ARBs or RD is having some positive roles to improve the function. That we already discussed. What are the advantages of RD? So I would strongly say yes, it works very well in all diabetic patients with preserved or impaired ejection fraction.
Ronak?
Yes, sir, definitely. All these newer drugs now with more affordable prices, that has helped us all, like us also, our patients also. They have less follow-ups, they have less readmissions, they have improved quality of life. So yes, it do help. May it be ARNI, may it be dapagliflozin, may it be other SGLT inhibitors. Yes, it do help.
Kinjal?
Yeah, I agree. This drug has made our life very much easy, basically patients, and many of our patients, basically diabetic patients, having heart failure, and using this type of the drugs, they will helpful in better outcome of this type.
Making our life easier, yes.
Yeah, only thing issue, if the patient who are very sick patient, the sickest patient, who have very low blood pressure, like 90 or 100.
Yeah, you can't do much.
These are the patients, they do not improve with it and they
You
get
cannot do anything for them.
Hypoperfusion. So these are the patients who really need the medicine, cannot tolerate them. That's a real sad part.
Very true. Unfortunate for them. Kamal?
So yeah, I use it frequently and it's made life easy for everyone. So I completely agree with what the other three speakers said.
Okay. So if I think we are getting late, so Ronak, if there are no more questions.
Yeah, only one last question.
Yeah, please.
One more, maybe to you only. That as a diabetician, what do you prefer in this combination, dapagliflozin with gliptin, dapa-sita or dapa other gliptins? What is your take on that?
So see, I was one of the biggest users of sitagliptin at that time when all the drugs were in patent, because sita had the maximum data. Thereafter, enligliptin came to India, which had, which didn't have data, but which had, real world evidence that it was being used in tons and tons because the price was very low. Now that DAPA and Vilda is off patent, I have not shifted. I still continue to use tenligliptin and I get equally good results. Because if you see, the gliptin group of drugs, they are otherwise neutral. They are very safe drugs. They don't do anything except reduce the HbA1c. A little bit, saxagliptin, little bit in heart failure or, something like that. Small things are there. But like, SGLT2 or GLP-1, they don't have any such things. So I don't think that, changing the gliptin is going to make real much difference either in diabetes or in the cardiac outcomes. You can use the gliptin which you like. I have been using tenligliptin for a pretty long time and I see no reason to change that. Whatever the evidence may be, because the real world evidence, I think the volume of tenligliptin which has been used in India is far outnumbering the total of all the other gliptins which has been used. And I have used it so long that I have not seen any side effects, so I continue to use it. There are people who still use sitagliptin, vildagliptin. There is a lot of evidence. And I think that is also absolutely okay. There is no question about that at all.
Okay. Any quick comments from VC sir or Kinjal sir or Kamal sir on this, or we can conclude with this?
I think we can conclude because we have summarized so many things, summary of summary.
Yes.
So Kamal can do a summary of summary. He's an expert professor. So
I have not heard Kamal since a long
Kamal
time,
can always do Kamal. So let him do that.
That's all kind of you, but you all are equal big geniuses. I don't think I need to summarize anything more. But yeah, I think we pretty much covered this slide, which is in display, covers everything actually. This is the good summary slide. You have all the new emerging pillars and you have the 4 classical pillars. This summarizes everything. I think the slide tells us where we are headed. Omective mecarbil has fallen out of vogue. FDA approval has got lost. I think what is missing probably is the vagal nerve stimulation. People are talking about CCM, which is another emerging and approved therapy now. Maybe we'll have some data emerging for some other therapies which are still under repair. But again, edge-to-edge repair is something that is coming up in big way for the times to come. So I think we pretty much know where we are headed. The 4 pillars are here to stay pretty strong. As of now, we know the heart failure therapies, and we'll probably have more hydrolyzine nitrate, FCM, vericiguat, digitalis, completing the octave, as I called, of heart failure.
Thank
only
you.
Thing missing in this, only thing missing in this slide is correction of heart failures, a root cause of heart failure by the surgery. Yes, for example, patient with severe AR or MR, and you replace the mitral valve or aortic valve, especially in aortic stenosis, improves LV function dramatically. Same way as bypass surgery. So that should be added because that plays a huge role in improvement in LV function. That is the only thing not added in this slide.
So I think we'll come to the end, and Dr. Ajay bhai, can you conclude and propose a vote of thanks?
Right, sir. Right, sir. So on behalf of Acmedix, I thank you all, especially the expert speakers like Dr. Professor Kamal Sharma, Dr. Kinjal Bhatt, Dr. V.C. Chauhan, sir, and very nicely moderated by Dr. Ishwar and Dr. Ruparelia. I thank you all. I thank all delegates also for joining such an interesting discussion, and hope everyone must have enjoyed a great, interesting discussion. Acmedix is always the front runner in supporting all scientific activity, and in past, today, and tomorrow, we will be with you for all academic activities. Acmedix is very special in giving you a very ultra economy with a high quality products, even the newer molecules. Very recently, the product like Arni, which has gone out of patent, we were the first to give you at just 8 rupees a tablet of 50 milligram. So that's the culture we have, and that's the strategy we have to be in the market. Once again, thank you so much, and good night to all of you from Acmedix. Thank you so much.
Thank you. Bye-bye, everybody. Kamal, bye. Kinjal, Dr. Chauhan, Ruparelia, bye. Good night.
Bye.
So nice.
Bye.
We had a nice
Good night.
Thank you so
Good
much.
night.
Thank you, and good night.